Right, shut up now. Pardon, Joe? What did you say? I thought you were answering me back. I thought you were giving me a bit of lip then.
It's Jared, really?
What was that? What? Yeah.
Sorry, I didn't realize it was on the recording.
Is that how the recording's started?
Oh. Right, don't forget Friday in here, 9 to 11. Friday, 9 to 11 in here. It's on the unit outline in week 1. Remember the unit outline? We cover the last part of the course. And so on Friday, I'll cover the last part of the course, give exam hints, talk about the practical exam, all the final bit of stuff that we haven't covered yet. It'll be recorded, I hope. Well, I mean, it's put in the computer to be recorded, so I hope it works.
I'm assuming this lecture is coming out in the next couple of days.
Have I let you down at all this semester? Once. Yes, they will.
When was the next test? Do you want to tell us now or 24 hours before?
Oh, aren't we hard done by? Ooh.
It's been a long semester, Steve. I'm sorry.
Hasn't it ever? Right, today we're going to cover 2 different sterile sites. One will be the blood and one spinal fluid. There's some link in some ways in that they're both sterile sites and the kinds of bugs involved are similar, but apart from that they're quite different. So first of all, blood that circulates is sterile, but I think you'd be amazed how often you get bacteria in your blood during the day, because lots of mucous membranes are close to your bloodstream, have heavy normal flora. Say your gums, for example, and your bowel. And lots of times there'll be a small breach in those surfaces and you'll be transiently bacteremic. When I say transiently, there might be, I don't know, 10, 100 bugs in your bloodstream any one time for about 10 minutes. Then they're cleared by the liver and the lymph nodes and they're gone. But transient bacteremia isn't that uncommon in a very, very strict sense. True bacteremia that's ongoing, that annoying noise, don't know. The true bacteremia is when the bugs are in there and they're persistent. Now, between bacteremia and septicemia, the difference is really only clinical. So septicemia means there's bacteria in your blood, they're rapidly multiplying, it's going to reach a crescendo eventually when you're going to die, and you're clinically ill. So bacteremia is normally subclinical, septicemia is clinically apparent. In both cases though, there's bacteria in your blood, and there'll be a grey area between when bacteremia becomes septicemia and not, and it depends really on how sick you are. When you have true septicemia, it's got a really high mortality rate. Not surprising really, you've now got bacteria in your bloodstream and they're growing in there. It depends on the organism. Now, gram-positive bacteria have a lower mortality for septicemia than gram-negatives. Excuse me. There's a couple of reasons for this. The first reason is that even though gram-positives and the ones that cause septicemia are probably more pathogenic, they only cause disease if you're relatively well. So they're more aggressive, but because you're already quite a healthy person, you've got a better chance of recovery. Now, gram-negatives inherently are less aggressive. This is just a general rule, not always. But they cause septicemia or sepsis in people who have got underlying disorders, and therefore recovery is more difficult. The other probably more important factor is that part of the cell wall, not quite true actually, part of the cell outer covering in a gram-negative, the outer membrane, is composed of lipopolysaccharide that has endotoxin activity. So endotoxin really means toxin within. So endotoxin is a toxic component within the cell wall, cell membrane of gram-negative bacteria. So when you've got a gram-negative bacterial cell in your body and something kills it or it dies, then all the bits of cell wall that are left over are active as endotoxin. And as they multiply, they make more of this endotoxin component than they need to make more cells. So as they metabolise and grow, there's free endotoxin in your plasma. When you try and kill them with antibiotics, most antibiotics will work by lysing the cell wall. So often after you treat somebody, there'll be a crisis where they get more sick initially, because as you kill the bugs, that's a good thing, but they release a lot of endotoxin. And the endotoxin, what this does is it activates a whole range of other host mediators of inflammation, cytokines, etc. And what these host mediators do is activate other pathways. So you end up with a fever, your capillaries become more leaky and they dilate. You make fibrin clots and the clots lyse, and there's bits of fibrin floating around that can form emboli, and then you coagulate intravascular. All of this whole thing here is what we call toxic shock. And you die from toxic shock when you have sepsis. The term sepsis just means really septicemia. Oops, where's my page down button? There it is. That's somebody with septic shock, and that's from gram-negative bacteremia. This one happens to be from meningococcus, but it could equally be a Vibrio or an E. coli or a Klebsiella. In the end, it's a gram-negative. And all of this is, bleeding under the skin, clots being lysed. If you vasodilate and your capillaries become widened, you actually lose cardiac output because there's more volume to suddenly fill, and your heart's still pumping, but there's less blood circulating. So you lose cardiac output, you lose renal function, and if the capillaries start to leak and you lose actually intravascular fluid, it gets even worse. So in the end, it's a cascade of events that just keep going and going and going and escalating. And once you're in that stage there, recovering from that stage there is pretty difficult. You've got to take a lot of high intensive care to recover from that. Now, what do you mean by sepsis or septicemia, and how do you get it? Oh, does that annoy you? It's half the word showing, and I can't get it to be right on. Oh, that's better. Bit of OCD. Okay. Septicemia is not contagious. You can't catch it from somebody else. So we talk about developing septicemia rather than catching septicemia. And it's nearly always a complication of some other primary infection. One of the most common is a UTI. So the most common cause of sepsis is E. coli, because it's the most common cause of UTIs. And often you'll get a UTI that's poorly managed, or is very aggressive, goes up towards the kidneys to cause pyelonephritis, and from there gains access to the bloodstream. Or you might be catheterised, and catheterisation involves trauma and blood loss, and if you bleed, then sometimes there'll be backwards flow of organisms into your bloodstream. So all those things lead to an opportunity for the bacteria from the primary site of infection to get into the blood. So about 25% of septicemias are primarily caused from a UTI initially. Lots of times a respiratory infection can lead to septicemia, and this applies mainly to infection of the lower respiratory tract, so pneumonia. In fact, one of the ways you can diagnose pneumonia is to take a blood culture and find the organism in the blood, because often with pneumonia you have transient bacteremia, and because it can be hard to get good specimens of sputum, if the blood is positive, it's a good indication that that same organism is in the lung. So strep pneumos, H. influenzas, normally you find with the bugs that cause sepsis have to have some capacity to invade. The other aspect where respiratory bugs can cause sepsis is from colonisation of the upper respiratory tract. Classically, things like Neisseria meningitis, the meningococcus, HIB, so type B H influenzae, they start off colonising the nasopharynx. There is no primary infection that is colonised, but from there, for reasons that are really hard to tease out, sometimes they invade from the nasopharynx to the blood. And once they're in the blood, they multiply unchecked and you end up with sepsis. So HIB sepsis, if you go back in time, that same bug would be in the throat. And every time you get meningitis, go back in time, the same bug would be in the nasopharynx. Any kind of deep abscess, as the abscess swells and builds up pressure, there'll be bugs leaking out of there into the blood. So Staph aureus sepsis, you know, just tomorrow you're sick and someone takes some blood from you, blood culture, and you're positive for Staph aureus. The first question will be, where did it come from? There's got to be a site somewhere in your body with an abscess that's got Staph aureus. It just can't jump in there from nowhere. It's got to get there from a primary site. So that's important. And then the last bit will be any kind of major wound, often following surgery. Almost always, bacteremia or septicemia are monomicrobic. That is one organism. You don't get Staph aureus and E. coli septicemia. You get Staph aureus or you get E. coli, not both. The only time you see polymicrobic sepsis, and this is still really uncommon, is following a surgical wound that's got lots of organisms in it, or the surgery in the bowel where there's massive leakage of organisms from a site full of normal flora. And the other point, which we'll talk about more, I think, next on Friday, is the term of a venous catheter. So plenty of times you're so sick, you need a catheter in through a central vein. Often there'll be peripheral on the arms, but the big ones go in here in the chest. And they provide access for all sorts of drug therapies. Imagine a big tube as big as a biro, not that big, but as big as a biro, stuck in there, and it's left open to get access to your bloodstream. Well, bugs get down through there. And the most common cause of venous catheter-linked sepsis would be some kind of skin flora that might be what kind of organism do you think? That's a Staph aureus. Staph aureus is not skin flora. Staph aureus is nose, throat, groin, and axilla. NTGA. But this is going to be caused by code-negative staphs, epidermidis in particular. They're low virulence, but if you've got a venous catheter in place for a reason, because you're bloody sick, then these bugs of low virulence can then become quite nasty. As well as general bacteremia / septicemia, there's one special localised infection that's intravascular, and that is endocarditis. A pretty important infection because it's interesting from a microbiology point of view, because you find strange bugs in this disease. So the hallmark of the disease is there's growth on the heart valve, or on the endocardial surface. The endocardial surface is the inside surface of the heart, where the blood is, not the outside of the muscle, inside. And within the endocardial surface, the heart valves themselves are really, really important as a focal point of infection. And what happens is when the bacteria grow on the endocardial surface, especially the heart valve, as they grow, you make an immune response, send in fibrin and platelets, and you end up with a growth, a physical growth on the heart valve that contains bacteria, platelets, fibrin, inflammatory cells. And that growth physically impairs the function of the heart valve. It should be there doing this, and it's got this big chunk on there and it can't wobble properly, so it becomes dysfunctional mechanically. So then you get heart failure because your heart can't pump properly. And then when bits of these growths, vegetations break off, you've now got this bit of stuff floating around your bloodstream, and this bit of stuff contains organisms, and it's quite big, and it goes until it hits a blockage and stops. Then you end up with little infarctions down below that level of the blockage, and that's infected, so you get what's called septic emboli, and there'll be small bits of infection, different parts of your skin, often in the extremities, and you'll end up with hemorrhages in the fingers. That's why in that previous photograph you saw that person's fingertips were all black, because the emboli snap off and go and block the capillaries. So endocarditis isn't a great disease to have. I don't want to have it. What makes, so if you imagine that we do often get transient bacteremia. So to cause endocarditis, there must be something that puts some bacteria in your blood. Well, how do they get there? It may be you've got primary sepsis, but it's unlikely. It occurs most often from transient bacteremia. When you have transient bacteremia, in goes the bugs from some other area somewhere, and they're in your body floating around. Because you're so good at clearing them, unless they find somewhere to stick on and become protected from your efforts to remove them, they get removed. So if you're wandering around and you're about to hit by some antibodies or some white cells, and you go, oh, heart valve, I'll just stick right there. But the heart valves are normally non-sticky, like Teflon, and they can't stick on. So the heart valve being colonised presupposes some damage to the heart valve that makes it sticky. So the common things that predispose to your heart valve being colonised would be rheumatic fever. Because we know rheumatic fever from a previous group A strep many years ago causes inflammation of the heart valves. When they're inflamed, they get all grainy and lumpy and not smooth anymore. You might have some kind of prosthetic heart valve. Yours is all broken, you get a new one, either made of plastic or from a pig's heart valve. It's no longer quite the same. It's not yours anymore, and it's not quite the same fit, a bit lumpy. So, you know, almost 2/3 of the patients who get endocarditis have some prior lesion on the heart valve that puts them at risk. Some people have no known predisposing event, but it's possible. When you have endocarditis, high mortality rate, and there are two different kinds of endocarditis. These are broad categories where there's grey areas in between, and it's just helpful to put them in groups just to understand them, but there's no rigid separation. With acute endocarditis, it involves people who are previously pretty well, with no obvious signs of a damaged heart valve. Normally involves bugs that are aggressive, strong pathogens, Staph aureus, Strep pneumo. And you go from being quite well to being very sick to then being dead week to 10 days without really quick diagnosis and quick therapy. Now the other is subacute endocarditis, much more common. And subacute involves bugs of low inherent virulence. Things like coated egg staphs, enterococci, and viridans type streps. And think of where these bugs live. Viridans streps, respiratory tract, good point of access to the bloodstream. Enterococci, bowel, mucosal surface, good access. Coated egg staphs on the skin, get in via breaks in the skin, or most often by a venous catheter. When it's subacute, it goes from being normal to slightly ill, vague symptoms, bit of chest pain, funny circulatory system symptoms, bit of fever, not feeling quite right, but you can't really pinpoint it. You know, poor heart performance, and it gets worse and worse and worse. But it might be 6 months before you're really, really, really sick. And when you treat them, it can take months to recover. So it's a slow process. Also, it's called subacute or chronic endocarditis. Normally involves bugs that are not very virulent. Overall, the majority are caused by streps. And in that group, I mean also include the enterococci. If you go to have your teeth out, a big extraction, often you get asked a question, do you have a heart murmur or any history of rheumatic fever? Because if you've got history of rheumatic fever or you've had a heart valve replacement, having a tooth out is a big risk for bacteremia. Big hole in your mouth full of organisms, they go backwards. So if you say, yes, I've got a history of this and my heart valve is a pig's one, what are they going to do? Give you antibiotics. So if we treat you for the period of extraction of the tooth and just afterwards with ampicillin, it protects you from enterococci and viridans type streps. So you're reasonably safe. Because really the bugs in your mouth are the risk, and penicillin is going to cover all those, but they normally use ampicillin. So if you look at it like this, what are the major causes of endocarditis? If it's acute, Staph aureus and strep pneumo, that's for acute. If it's subacute, enterococci, viridans type streps, and calculation negative staph. And then all the other bugs that might cause endocarditis. What's the sign for infinity? Is it that sign? Oh, I can't draw one. One of those. The range of bugs that can cause endocarditis is infinite. And there's almost a game in publishing. If you find a bug causing endocarditis not been found before, you publish it. So there'll be journal articles, like billions of them. First ever case of this bug causing endocarditis. First ever case of this bug, and there's just millions of them. So any bug can cause endocarditis, provided there's enough of those risk factors and there's transient bacteremia. For example, you'll see cases of Propionibacterium causing endocarditis as well, because its skin flora gets in the same way as Koenigsegg staph do. So any bug can cause this disease, and it's just like a game in the end. Good game though. Oh. Do I press Control and plus? There you go with that. So this is a normal endocardial surface, and it's meant to be quite smoothish, so bugs would hit that and not find somewhere to colonise. And the bottom one is one damaged from prior rheumatic fever or something similar. Inflammation, red cells, platelets, fibrin. You can imagine now, any bug who wanders past there is going to hop in, because it's lovely and cosy in there, and they're protected. Here's the same one. Staph, 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 staph. All those staphs in there. Lovely and happy in there, attached. This is normal tissue. That's vegetation and inflammation from endocarditis. So you can imagine now, that tendon that runs and holds that valve together just isn't going to work. The whole valve is so compromised. That valve's stuffed, as is the patient, which is why there's a photo of his heart. Now, I've got 64. Yeah. Okay. Here's the bit you've got to understand and learn completely. It's about the laboratory. What do we do? So when we take a blood culture, we think you've got sepsis, either septicemia or bacteremia. We want to see what's in your blood. And when you take blood cultures, there are a number of overriding considerations to think about. The first one is we want the time from when we collect your blood to when we know that you are positive to be as short as possible. The sooner we know that you've got sepsis or bacteremia, the sooner we treat you, the sooner we're all happy. So minimum time to positivity is really important. We also understand that sometimes a small number of organisms in the blood can still be dangerous. So we want our system to have maximum sensitivity. Ideally, if there's one organism in your blood, we want to culture it. Now, it won't work that way because if we only take 10 mils of blood and you've got lots more than 10 mils, so the bug might be there when we bleed you and you'll miss it. But you want to make sure that if he's in that syringe, there's one organism, we culture it. So I want to have good sensitivity. We have to accept that everything's about cost. And we want our system of blood culture, collection and monitoring and manipulation to be cost efficient, because it's often a high volume specimen. Lots of blood cultures are taken in hospitals, for example. And if we spend all our time playing with them, then they become very expensive. So if they're automated, it's really helpful. And we want to make sure that there's no contamination. The biggest drain on resources is a blood culture that's got contamination with bugs that did not come from that person's blood. Because we won't know where they came from. Oh, it's bloody E. coli. And then after all you work up, you find that the E. coli dropped in there from the ceiling, then you've wasted a lot of time. So we want to minimise contamination. What's the most likely contaminant in a blood culture? Coagenic staph. And probably one of the most common significant organisms from blood cultures is coagenic staphs, because they cause bacteremia in sick people with catheters in place, venous catheters. So the real shit now is the most common contaminant is the same organism as the most common isolate. So you don't end up knowing till the very, very end, and even then you're never quite sure whether what you've got is real or contamination. So make sure we minimise this completely. So, specimen collection. When we collect your blood, we must be aseptic. Might sound pretty simple. So, here's your bottle of broth, and here's your patient's arm. 1, 2, 3, 4, 5. You've got to get your syringe into there, take the blood out and get it into there without contamination. So when you take blood, prep the skin, line up your spot where you put the needle in, nice and alcohol, nice and clean, and then when you go to put it in, don't have a second feel, because that's where you get contamination with your fingers. So get it all lined up, prep the skin, and memorise where to go in. Wear gloves. There's less bacteria on your fingertips with gloves on than there are on your fingertips without gloves on. So wear gloves while you do venipuncture. It's helpful. So in it goes. On the cap here, there's a rubber septum where you put the blood in. Clean that with alcohol as well. Otherwise, there's possible bugs on the tip. There was, for some time, a policy where after you took the blood from the person's arm, you would take the needle off your syringe and chuck it away and put a new one on to put into there. Because they felt that the biggest area for contamination was bugs on the needle tip from the skin on here. What they found was over, say, a 12-month period of monitoring this, the number of times that staff got a needle stick injury from playing with the needles on and off was so huge compared to the possible benefit of doing it, don't do it anymore. Just leave it on. And then put that into there, in goes your blood. But minimise contamination. Think all the time, what's my risk of contamination? There's 2 points for contamination. One is collection and one is manipulation once the bottle is in the laboratory. So your first thing is minimise contamination during collection. When do you take the blood culture? There's 2 issues here. What they've found is if somebody is bacteremic and we take one single set of blood cultures, now Blood cultures come in pairs. There's 2 bottles. One bottle is aerobic and one bottle is anaerobic. So you always take 2 at the same time. You take 20 mils of blood, 10 mils in each bottle. You normally take 3 sets for one episode of investigation. So it'll be 1 set of 2, second set and a third set. If you're bacteremic and we only take 1 set, our chance of finding the organism is about 70%. If we take 2 sets, it's raised to about 90%. Do 3 sets, it's about 95% or more. So it's standard practice to take 3 sets. You take 3 sets over 24 hours to maximise the chance that your collection coincides with them being bacteremic. Because if it's an abscess, it comes and goes. The bugs are there, then they've gone, they're there again, then they're gone. So you want to have it spread over time. The best time to take the specimen is just after a spike in temperature. Sorry, just before a spike in temperature. Because a temperature spike occurs in response to the bugs being in your blood. If you wait till they spike, it's probably a bit too late. But you can't take the specimen backwards in time. You can't, oh, they spiked, I've taken it half an hour ago. You can't do that. So you try to monitor their temperature over, say, 24 hours and predict the spike. Pretty hard to do. Most importantly is 3 collections in 24 hours, roughly spaced evenly apart, which means 8 hours. You might do 1 at 7 in the morning and then 1 early afternoon and 1 late evening. What it doesn't mean, and what you see all the time, is people get a bit lazy. Oh, 3 blood cultures, oh, I'm busy. I'll do 1 now, put them over there, have a cup of coffee, do another one, and then another one. I've seen 3 taken in under an hour. It's pointless because although you're getting more blood volume, which is always helpful, you're not spreading it over time, so there's less chance of getting the bugs at the right timing. So it's 3 in 24 hours where you can. The more you collect, the more blood you collect, the more chance of finding the organisms in the blood. So take more volume, not less, except the bottles of broth are designed for a maximum volume. So most bottles are designed to accept a maximum of 10 mils per bottle. It's all to do with the ratio of blood in the broth. The broth dilutes out antibodies, antibiotics, all those sort of things that are antibacterial. And the goodies in the broth are designed to work best at a concentration achieved by adding 10 mils more liquid, which is blood. If you add 20 mils of blood to a bottle designed for 10 mils of blood, it works worse than adding 10 mils of blood. If you have spare blood, there's 2 things you can do with it. Chuck it away or use it in another bottle. If I've taken some blood and I've got 25 mils and I go 10 mils in there, 10 mils in there, I've got 5 left over, get a 3rd bottle, another air bottle, and put it in there. But don't add more to one of the bottles. Maximum of the bottles is what's on the bottle. It says 10 mils of blood, please, not 11.5 or 12. If you have a situation, say, with a child, and it's bloody hard to bleed kids, you might get 2 mils or 3 mils and feel good about it. If you've got a child with sepsis and you only have 3 mils, I've got 3 mils of blood. What will I do with it? I could do 1.5 there and 1.5 there. Or I could do 3 in there, or I could do 3 in there. What would I do? I know what I'd do. I'd put 3 in there. Because for a child, the kinds of bugs that you see causing sepsis, Strep pneumoniae, H. influenzae, Neisseria, all those bugs grow better aerobically, and some of them won't grow at all anaerobically. So unless the person has got some kind of abdominal injury, of those two bottles, the one that's expendable is the anaerobe bottle, roughly speaking. So the broths in the blood culture bottles, the broths themselves are incredibly enriched broth. It's not just nutrient broth, it's nutrient broth plus cofactors and enzymes and other nutrients. It's full of stuff. It's great broth. And in the bottles, aerobic bottle, anaerobic. There's broth in there, and up there is gas called the headspace. In the bottle that's aerobic, the headspace gas is carbon dioxide. For the ones that are anaerobic, the headspace gas would be nitrogen and other things that are inert, but not oxygen. When you grow blood cultures for at least the first 24 hours, and preferably forever while they're still being used, you have them on a shaker. And the shaker does a number of things. The shaker that shakes the bottle, just roughly, helps this gas disperse through the liquid and make sure the bugs down there getting all that nice CO2 and oxygen. And bugs grow more quickly when they're being lightly shaken because it gives them more chance to get nutrients and be exposed. So they're on a shaker. When you put the blood in the bottles, if the person has true septicemia, they're sick, that bottle, so how do you call a bottle positive? If I say the bottle is positive, that means there are bacteria in that bottle, and they came from your bloodstream. So a bottle that's positive was actually positive from the very minute you did the collection. But there's a limit to when we can detect positivity. So if I think about this, here's a graph, along here is time, and this is 0 bugs. If the bottle is negative and there's no bugs in there, at 1 day, at 2 days, keep going to 7 days or 10 days, there's 0 bugs. It's a flat line of 0 bugs forever. If there's, thousands of them, then it would do this really quickly. But if there's only a few bugs in there, it might be a very, very slow increase that then builds up. Depending on the way in which you detect the presence of bugs in that broth, there'll be a threshold at which you can detect the growth. And it might be like this, for example. There's a threshold there, which means this one here becomes positive when the number of bugs by the black line hit the threshold. Supposing your way of checking for positivity is to every morning go in, take some broth out of that bottle of broth and do a gram stain. A gram stain that's positive says there's bugs in there. Well, the threshold for detecting growth by a gram stain is pretty high. You've got to see them visibly. And the threshold for detecting growth with a gram stain would be lower for gram positives, because they're easier to see, and much higher for gram negs, because gram negs are bloody hard to see because they're pink and all the cell debris in the broth is pink. And on Friday, so on Wednesday when you do the prac, you do a gram stain of a positive bottle with E. coli and a positive bottle with strep, and one is really easy and one's really hard. So here's the issue. This threshold can be a bit of a nuisance. The bottom line, though, is this. We normally wait at least 7 days before we say the bottle is negative, because very, very low starting numbers of bugs might not be detectable for 7 days. But most go in 48 hours. I mean, if you're strongly positive, you'll go straight away. Now, here's the issue. You just redraw this graph. So, if we start with it goes up, and there's the threshold. Okay, now the standard historical way of doing blood culture monitoring was like this. You took the specimen, blood, put it in the bottle, put the bottle in the incubator on a shaker, let it shake. Next morning you came in and did what's called a blind gram stain. In other words, you did a gram stain of the broth at day 1 in the morning. Now, if there weren't many bugs there was some there, it's positive, start with. There's not 0 bugs there, there's some there. But the number of bugs there was below the threshold to detect on a gram stain. You call that negative. It's positive, but you call it negative. And you come in the following day, and it's still negative. It's somewhere between the second day and the third day hit the threshold. This occurred in the middle of the night. So because you're doing the checks only daily, you've now wasted a whole half a day. So doing gram stains just as the only method is pretty poor. Now, one way of getting around this, the gram stain threshold is up there, but if instead of doing just a gram stain, we take some broth out and culture it, you can imagine that a broth can be positive for bacteria, but you can't see them. But if you subculture that broth, it'll grow, and you see colonies. So the culturing threshold is much, much lower. Positive right there. But of course, even now, you're culturing it sometime after the event. Now, always, when you take the broth out of the bottle to do a blind culture, that is culturing it anyway, it will take you 24 more hours to see the colonies. So even though you do the collection right there, and it's clearly above the threshold, so at day 2, when you take the blood out of that bottle and culture it, the number of bugs there is above the threshold of detection by culturing. You won't know for 24 more hours. It's a hopeless system. So if all you do is what's called a blind gram stain and a blind subculture, it's really inefficient. We want some way of changing this. We want 2 things to happen. We want this threshold to be as low as possible, and we want to shorten the time to when you detect it. This is how we do it. One way is to use these kinds of bottles. It's called a signal bottle. And even this now is quite old-fashioned. And it's semi-automated and semi-continuous. Continuous means, so if I check on a Monday morning, Tuesday, Wednesday, I call that discrete checking. There's a discrete number. 1, 2, 3. Continuous means you're checking it much more often than that. These bottles are good because what happens with this bottle is there's a needle. Let's just draw this for you. Here's the bottle. And a needle goes all the way from there into the liquid. This is all sealed. Up there is a reservoir. Up there's a screw cap lid. As the bugs in here grow, all bugs that grow make gas. As they grow, they make gas. The gas hits the headspace, expands and pushes the liquid down. As the liquid is being pushed down, it goes up the needle into the reservoir. So seeing broth in the reservoir is an indicator of gas in the bottom, which itself is an indicator of growth. And we call this broth up there a signal, which is why they're called signal bottles. So once the broth hits this top bit, the bottle is presumed positive. And then I come along, undo my screw cap lid, take some broth out of there, gram stain, have a look. The reason that these bottles are good is like this. With the old method of doing a gram stain on the subculture, I had to go in, get the bottle out, put a syringe through the rubber stop at the top, suck the broth out, do a gram stain, subculture, pain in the neck, do it Monday morning, Tuesday morning. For the whole of Monday, I'd wander past the incubator, the bottle is there, I'd open the door of the incubator, hello bottle, and then close it again, and it's done. Because you just do it once a day. But if with these bottles here, every hour I wander past the incubator, open the door, look for a signal, no signal, goodbye bottles. If one was gone positive at lunchtime, I pull it out. This is what I call semi-continuous monitoring, because as long as I'm wandering past the incubator having a look, at the time I go pos, I see them. It's not just once a day, it's every time I feel like having a look. They're good. The other method is called a Castaneda bottle. These sound good in theory, but in practice they're not that good. One of the problems with this is once we detect growth, it takes 24 hours before we have growth on a plate to do more tests with. So this method has a bottle like this, and one side of the bottle is made of agar, solid agar. Here's the broth. Every day you go in there, and to do a subculture of the broth, all you do is tip the bottle on one side, all this broth hits there, tip it back again, and you'll get colonies on here. Then when it's positive, you can stick your loop in there and pick them off. Sounds great, except we're all used to seeing colonies on nice dry plates. These are always so wet. The colonies don't form as colonies, they form as films of growth. So they're not that good. They're okay, but not fantastic. Almost everyone now has some kind of automated system. These are much better. There's lots of them, whole different companies that all do the same thing. What you have is still a bottle of broth, but something in that bottle of broth has been designed to detect growth and send a signal external to the bottle. The first ever ones were called Bactec, and the Bactec machine now is the standard benchmark machine for doing bud culture bottles. In the old days, what happened was the glucose in the broth that the bugs used to metabolize to grow was labelled with radioactive carbon. And when they used the radioactive carbon from the glucose and made CO2, the CO2 they gave off was radioactive. And the machine would come along every hour and put a needle in the top of the bottle, suck the gas out and analyse it. And as soon as the gas was radioactive, the bottle was called positive. And the machine would have a little alarm. It would just beep at you. Beep, beep, beep. You come along, on the front of the machine, it would say, bottle 64 is positive. Open up, pull out 64, do a gram stain. It was great because it was continuous. They monitored all the time. So every hour, it's on a little conveyor belt, goes in, gets sampled. Really good. The slight problem was occasionally, because it was the same needle on this machine, on a little conveyor belt, doing this, sometimes bugs from this bottle got transferred to the next one. Not very often because it was sterilised between uses, but there was some risk. And the idea of putting things into a sealed bottle is also a bit, to me, offers chance for contamination. When we handle bottles and do our gram stains, that's the time we put in bugs from our own skin in the bottles. So the newer methods, what they do is they have some sensor on the bottom of the bottom, on the bottom of the bottle. And the sensor can detect growth by changes in the chemistry of the broth. And they have a detector that will change colour. And now the machine looks up through the bottom of the bottle to see a colour change. And it says, this is positive, and the bell goes off. There's now a myriad of systems that do different ways to detect growth. But they all do the same thing. They all detect growth. And if you think about this, gram stain positivity, high threshold. Culture pos, high threshold. All these systems have a much lower threshold, way down there somewhere. They go pos much, much quicker, and you find them more quickly. So it's much, much better. Almost all labs now of any size have a machine to do bug cultures. If you are still doing it manually, you are so far behind best practice, it's not funny. It's really, really ordinary. Okay, so we do blood collection and the bottle is incubated and it goes positive at some time. We've made advances in decreasing the time it takes to go positive and how soon we know it's positive by having the machines that are automated. So this has been compressed over the years to become quite short. Once the bottle is positive, by whatever mechanism you want, gram stain, culturing, machine, bottle is positive. What do you do now? Always the same thing. Do a gram stain. Do a culture to get more organism to do more tests with that you might want to do downstream. And where possible, do a direct test for sensitivity. Now, I mean, you can down here, when you've got pure growth, do a controlled sensitivity test and identification. Between there and there is 24 hours. You're much better off doing this test up here, if you can do it direct, from the bottle. The bottle now has active bug in there, and lots of it. By the time it goes positive, there'll be a lot of bug in that bottle. There's only one organism, it's pure. In other words, you've got a suspension of bugs in a broth, which is what you do from here to there anyway. So these are pretty reliable. Take the blood from the bottle, dilute it with some saline, and use that to inoculate your plate and add your discs. And it works reasonably well. It's not standardised, but most times between a bug being susceptible and being resistant is a big change of zone size. So where it's really clear cut, these tests are quite good at giving early direction for therapy. Over the last little while, there's been some changes that improve this. Waiting for growth to occur and then doing identification is a bit ordinary. So it's possible now, once the bottle is positive, to do PCR for some of the key organisms. And then, rather than going 24 hours for culture, at least another 6 hours for identification, you go 3 hours, result. Good for Staph aureus. Good for E. coli maybe, or some other coliforms. It's also possible to do PCR for key markers of resistance. If you have Staph aureus in a blood culture, you're already pretty sad. What would make you more sad? If it was MRSA. And because MRSA is one known gene being present or absent, do a PCR for Staph aureus, do a PCR for the MEK gene. If it's positive, it's MRSA. Then you use vancomycin to treat them with, as opposed to doing something else and then realising after 48 hours it's the wrong drug. Much better do it quickly. So we can do things on the broth that's positive if you're a bit inventive. You can now also do MALDI-TOF directly on the broth. You've got to be careful though, because some of the proteins in the broth and in the liquid and the cells can interfere with the signal you get from the MALDI-TOF. So there's various techniques you can do to modify that to make it work. But they do now do routine MALDI-TOFs on the positives. They would still always do full culture and use this to check the reliability of the results that are interim results. But it's pretty helpful. And the last little bit of our interpretation. So you have a positive. Is the bug you've grown from this blood significant or contamination? Almost always it's bloody easy, because if you've grown an E. coli from this bottle of blood, where could it come from other than the blood? E. coli is not a common contaminant. It doesn't float around in the air. So E. coli's, if it's always positive, it's always significant. But the one we worry about most of all is Koenig staphs. And sometimes Staph aureus. I mean, we do have Staph aureus on our skin. We shed it from our noses. So things that help you work out what's positive, what's truly positive as opposed to contamination. If you take 6 bottles of broth, that is 3 sets of 2, you would hope that if the bug is really from the patient, both bottles of one set are positive. It's hard to imagine taking 10 mils of blood, or 20 mils of blood, and putting 10 mils in this bottle, and all those bugs in that 20 mil syringe happening on the first 10 mils, and none in the next 10 mils. Not going to happen, is it? So, unless the bug is strictly aerobic or strictly anaerobic, the bug's facultative, it should be in both bottles. I can't imagine it wouldn't be in both bottles. So seeing the bug in only one bottle of a pair is a strong indication of contamination. Further to that, if you truly have bacteremia, you'd expect that bottles in more than one set over that 24-hour period would be positive as well. So you want both bottles in a set to be positive and more than one set to be positive where possible. And the bug's ID is obviously critical. If the bug is known to be contaminant like Bacillus cereus, common in the dust, Koenig staphs, common on your skin, but you've got to be careful because they can also be positive. What if you got 4 bottles that all contain Koenig staphs? But it may be that one of them is epidermidis, and one is Staph conii, and one Staph xylosis, and one something else. So you must make sure the bug that you grow from more than one bottle is the same organism. You can't always presume it will be the same. And that goes especially for Koenig staphs, because there's so many variants of Koenig staphs. We think one word means the same thing, but it doesn't. It just means the staph's got no coagulase, but it could be any of a dozen species. Okay, have a breather. We'll come back by my watch. It's 10 now. Come back at 10 past. And I'll pause. No, I'm not going to say it again.
That's on the recording.
Dear listeners, if you weren't here for the last 5 minutes, I've said some stuff that you've missed out on. Get over it. And thank Jared for letting me know it wasn't recording. You owe him a beer. There you go. So you'll see little peaks, 5, then sort of young adult sort of age, and then really old people. The signs and symptoms can vary, but they always reflect the idea that there's now infection of your brain. So you end up with, you can become non-responsive. Often you have really severe photophobia, don't like bright light. So early in the disease, early in the symptoms, it'll be, oh, it's too bright. Headaches, maybe fits, not responsive, loss of consciousness, the whole lot. And it can become really rapid. It can go from being not very well to being dead, 6 hours, easy. And I can tell you some stories, or I'll tell you some stories in a minute, about how fast this happens. And it still scares me even now. I can remember being on call at the LGH, this must have been 54, 30 years ago. And I had a phone call, I was on call, coming to a CSF. And I came in and I went to casualty, and a guy had walked in out of his own car to casualty, accident emergency, it's the new name, into casualty. I've got a headache, it feel really bad. They took a spinal tap. I was off in the lab analysing it. By the time I finished my gram stain and everything else, he was dead. He'd walked in. The guy was 19, and it freaked me out how fast it was from walking into being dead. He had meningococcus. And I can then remember the next day, after I'd handled the specimen, I got the flu. Headache, feeling really shit. And I was convinced, I mean honestly, I was so convinced I'd caught it. I went to casualty and said, oh, I think I've caught it. And of course they didn't, as if Tristram could go away and stop being a sook. But it's that scary because it can be that quick. So even with diagnosis and treatment, the mortality is very high. Because by the time you're diagnosed, you've got bacteria growing actively in your spinal fluid. So what are the risk factors? It's very complicated because you only get meningitis if you have a preceding bacteremia. The bugs go from nasopharynx to your blood, then to your brain. Most cases of meningitis do not involve symptomatic bacteremia. In other words, you are not also septicemic. The bug goes to your blood, can't survive in there, doesn't like it, but while it's there temporarily, can cross the blood-brain barrier, get into your spinal fluid, then it's cleared from your blood. You are blood negative, but you're brain positive, if you like. And there are obviously some clear host susceptibility issues that make some people prone to meningitis and others not. For example, you'd have 2 people exposed to the same bug. They both have it in their nasopharynx. One gets meningitis and one doesn't. That must be a host thing. You also know that some bacterial strains are more aggressive than other strains. So some strains that colonise the nasopharynx never cause meningitis. Other strains are aggressive. So it's a combination of certain strains having the right tricks to get into your blood initially, and then from there to your brain, and certain hosts being susceptible. There's a whole range of factors. It's not so simple. But we do know, though, that exposure is really important. If you are not exposed to the organism and don't become colonised in the nasopharynx, there is no risk. But being exposed doesn't mean you're going to get it, it just means you've got more risk than not being exposed. And we're exposed by other people, and it's in their saliva. So you see colonisation becoming more common in any situation where people share saliva, either directly or indirectly. So known risk factors: classrooms, close proximity to people, bars, where you share drinks or share cigarettes. Disgusting. So there's a risk. Now, there's a survey that looked at the rate of carriage of a certain type of Neisseria meningitidis. They were just keen to see what happened. And these were people on a campus of a university. And the carriage rate was 7% on day 1, 12% on day 2, day 3, 20%, day 4, 25%. So within 4 days of enrolling on campus, the carriage rate went from 7% to 25% because you're in close proximity with other people. And the risk factors that were independent of the time were whether you went to the bar, whether you drank out of shared glasses, whether you smoked. So risks are being colonised. In a small number of cases, you can have other things that put you at risk, but it's unlikely. Sometimes a skull fracture or a nose fracture can actually make you get meningitis, but it's very, very uncommon. And some kids have a shunting, so they've got an issue with drainage of the spinal fluid, and they have quite large heads because of the swelling of the fluid. They put a mechanical shunt in, and the shunt takes the fluid from their spinal space and drain that back into their peritoneal cavity, called a something ventricular shunt. And occasionally that can go backwards and get bugs from the peritoneal cavity up into the brain. It's very uncommon. How about the bugs that cause disease? It's all changing. What annoys me about microbiology is you write a lecture and within a year it's out of date because things change. It's not quite that bad, but 3 or 4 years. So historically the most common causes of meningitis across the board, strep pneumo, Neisseria meningitidis and H. influenzae type B. Since 1992 in Australia, we've had universal HIV vaccination. So HIV disease of any type, whether it be sepsis or pneumonia or meningitis, is almost unseen in Australia now because the bug system is vaccinated against. We've had a vaccine available for type C of meningitis since 2003. Now, with the Neisseria meningitidis, there's more than one serotype, meningococcus. There's type A, there's type B, there's type C, there's Y, and there's W135. And why they went from C to Y, and why W135 is there, not 134, don't ask me, I don't know. I'd like to know, it always bugs me as well. So the current vaccine that we all get in Australia is type C. And they chose that because for a period of time there, it was one that was known to be very aggressive and common in the community. If you travel overseas, you get one that covers 4 serotypes. You'll get A, C, Y, and W135. B has been a problem. Getting a vaccine for type B has always been difficult. And there's a number of reasons why, but the capsule on type B is different in the way it's formulated and has more cross-reactivity than the other capsules. Now, you can now get a vaccine for B. It's not widely available, but you can get one. And the push for this vaccine was from a country that wasn't Australia, but close to us, and it was New Zealand. Because type B meningitis in New Zealand was rampant amongst the Maori people. It was a big, big thing. They had lots of cases. So the big push came from New Zealand for that. So now it is possible to have vaccines against all of them if you want it bad enough. I think that in Australia, though, type C is the one that's still funded by the government, not the rest. If you want the others, you've got to pay for them. What's that?
Was they giving W1 to teenagers not long ago?
So, you're quite right. Well spotted, Bruno. Good one. what they've seen seriously in the last probably 18 months, a huge spike in W cases. Big spike, yeah. So you're right, they've now offered this because they monitor it. I wonder how they know there was a spike. What would there be? It's notifiable disease. That's why we notify diseases, to get the information. Yeah, good one, I like that. And strep pneumo, of course, is also now a routine part of our vaccination schedule. This won't apply though to all countries. Not all countries do what we do. So if you go somewhere else, it might be different. I think HIV now is virtually worldwide. The one country that amazed me that took a long time to catch on to HIV vaccination was Japan. They were about 20 years behind us. I think they did theirs maybe in the last 5 years, if that. And we've been there since the early 90s. So these bugs now are less common. The rough way it works is like this. You become colonised in the nasopharynx. And the bugs add here, so you're exposed, they add here. And the issue now is like this is hard to explain. Sometimes you find these things out just by being lucky and doing surveys at the right time. They've discovered that if you are a carrier of the meningococcus, there's no risk. If the bug is already there, happy with you, stay where it is. It's only when you acquire a new strain, and your greatest risk is the first 3 or 4 days after you acquire the new strain. So if you are a long-term carrier, the longer you've got this bug in your throat, the happier you should be because the risk is less for getting meningitis. It's normally when it comes to you new. So it's acquired flora is the risk, not your own flora. Now there's been plenty of times in my pracs where I've done throat swabs of students just mucking around doing our pracs, and I've spotted meningococcus in their throats. And you go, what do I do now? Do I say anything to them or do I ignore it? You ignore it because being positive for the meningococcus itself doesn't mean anything without other factors being in play. And if we went round and did cultures of everybody and were to treat everyone who was positive by culture, you'd never stop doing it. So it doesn't matter. If there was an outbreak on and I cultured you and you were positive, that'd be different. But just routinely, it doesn't mean any difference at all. Okay, then you must have a bacteremic phase. For some reason, the bugs must become invasive and you become bacteremic. If you have antibody from vaccination, this is where you're happy because it goes into your blood, knocked off, that's it, done. So the vaccine works as it has antibodies in your blood which stop the phase being bacteremic. There's also some strong evidence that if you carry some commensal Neisseria, like Neisseria lactamica, a non-pathogen, it either primes your immune system a little bit to protect you from the other meningococci, or it has ownership of the binding sites where the other Neisseria would come and colonise you. So you know that having other Neisseria is protective. Once the bug survives, it needs something to survive, and most of these bugs have got capsules, which is why they're good at getting into your blood and surviving there. This is the key here, getting across the blood-brain barrier. And most people, that barrier from things in the blood getting into the brain is very, very strong and robust, and it doesn't happen. It's common to be bacteremic, but uncommon to progress from bacteremia to septicemia. It makes sense. You think about this. We see septicemia all the time. E. coli, Staph aureus, you never see them in the brain. It just doesn't happen because the blood-brain barrier is so good. So if you get meningitis, something there is amiss, or you're just really unlucky. Once the bugs are in your meningeal space, it's all over because once they're in there, there is nothing locally in that fluid to mop them up. And from there, it's progressive. And without antibiotic therapy, you're toast. So here's a range of the bugs, and remember this will be influenced also by vaccination, but as well as HIV and strep pneumo and the meningococcus, there are other things as well. So group B strep is a classic pathogen of neonates, and the source is maternal. E. coli K1 is a special E. coli with a capsule, K for capsule, K1, and it's the serotype 1 capsule. It turns out that the capsule for E. coli K1 cross-reacts with the capsule for group B meningococcus. So an antibody against the K1 capsule will cross-react with the antibody against the Neisseria group B capsule. And listeria. Listeria is acquired by the mother, and the mother has transient bacteremia. All those things put the neonate at risk, either as a fetus or just after birth. So any kind of specimen from a neonate, your first thought's going to be group B strep, listeria, and E. coli. As you get older, they move away, become less common, and you then see HIV, Neisseria, and strep pneumo. In young adults, Neisseria is still the most common. As you get older and older and older, strep pneumo becomes more common. How many serotypes are there of strep pneumo? More than 10? More than 20? More than 30? More than 40? 83? And the vaccine covers, depends on your vaccine that you're having, covers either the top 23 or the top dozen. So there's still some risk. And in very old people, listeria then becomes important as well. Key now for how you manage meningitis is therapy and management is always done on clinical observation. You don't wait for the lab report. You wouldn't say, you've got meningitis, see you tomorrow when we get the results back. You've got to do it straight away. But the sooner we have results that can confirm what you think is happening, the better it is. So it's always an urgent specimen. You can't say, oh, CSF, I'm going to lunch now, I'll feel that in another hour's time. If you get spotted putting a CSF on the bench to wait while you do something else, you get growled at big time. So you want to be quick. When you treat them, you make sure you cover everything. So you always use drugs of very broad spectrum. And your choice of drug depends on the age of the person. One of the things to think about is that listeria is inherently resistant to all cephalosporins. That's a bugger because cephalosporins are often used because they're good at treating gram-negatives, like coliforms, and they're really good at treating strep pneumo and Haemophilus. So you've got to cover everything else plus listeria is the way you think about it. So you normally get at least one drug that's very broad spectrum, often two. Do you think you give the drug orally or intravenously? Absolutely. IV therapy means dosage, boom, levels in the blood straight away. Oral means dosage goes up slowly as you absorb them. And if you vomit, which you might do when you've got meningitis, it's all gone. So it's got to be straight IV therapy. Every now and then, and it's not common, if you have an organism that's multi-resistant and you can't use things like cephalosporins and penicillins, any drug you have for meningitis must be lipid soluble and be able to cross the blood-brain barrier. There's no point having all this drug in the blood if it's not in the CSF. Cephalosporins are great getting to the CSF, but some drugs can't. So if you're forced to use something like vancomycin, for example, you can't give that because it won't cross the blood-brain barrier. You give that by a spinal injection. It's got to get in there directly. And that would be a last resort, though. If we have a case of meningitis, because we know it's contagious indirectly, that is, I've got meningitis, which means I must have been colonised, and therefore you might have been colonised. If you're in close contact with me, you might be at risk. So we always give a prophylactic therapy to close contacts. So supposing tomorrow somebody in this class has been diagnosed overnight with meningitis, you'd be contacted and you'd all be offered antibiotic therapy to be prophylactic. We wouldn't say, I will culture you and only treat you if you're culture positive. We just give you the drug anyway. The drugs we use to treat someone who's sick are not the same as those we use to treat you to remove the carrier state. Some drugs are great at killing bugs that are growing and active, and some drugs are better at killing those that are just hanging around as colonisers. And the most common drug to use is called rifampicin. Rifampicin. And rifampicin as a drug is great to remove the carrier state for Neisseria, strep pneumo, HIV. The only downside with this is the drug is pink and your body fluids go pink. If you wear contact lenses, your tears go pink and you stain your lenses, so you've got to take them out. And you wee pink. Vaccination post-exposure is a bit pointless. The vaccines take months for you to seroconvert, so it might be useful as a long-term strategy, but it's no point saying, oh, you were exposed yesterday, let's vaccinate you. It won't work. Okay, what do? Our specimen that we get delivered to us is a CSF, a cerebrospinal fluid, and you collect that by a lumbar puncture. Has anybody here ever had a lumbar puncture? Most years I get one student or so that's had one. When you see one being done, you sort of understand why these specimens are so precious, because as a technique it's invasive, very painful and risky. It involves having the person lie on their side, curled up to expose their spine, and you put a needle in through there, into the spinal column. And it's normally quite a large gauge needle. And you don't suck the fluid out, you put a needle in with a syringe with no plunger in it. Because if you suck anything out, you lose all that pressure suddenly, you're going to collapse. So the liquid drips out of the other end of the needle into the tubes. And they've got to be anaesthetised and prepped. You can't just go, oh, bugger, can I have some more, please? It's really hard to do, so you've got to be careful with it. You normally get 3 tubes, and they fill them in order. So they put the needle in, fill the first tube, about a mil, next tube, about a mil, next tube, about a mil. So 3 tubes you normally get. It's pretty important to keep these tubes for analysis in the order that you get given them. So it'll go to biochemistry for measuring glucose levels and chloride levels, everything else. But for us, what we want to get is look for turbidity. The fluid should be opalescent, almost like water with a bit of a shine to it. Should be no colour and not turbid. If it's turbid, turbidity equals inflammatory cells and bacteria. Turbid CSF, disaster. Clear is good. Sometimes there'll be blood visible in the spinal fluid. There are 2 reasons for blood to be in the spinal fluid. One can be a traumatic tap. In other words, put the needle in, I missed it, hit a bit of bone first, bent the needle, pulled it out, got another one, messed about, and you're bleeding from the tap. If it's traumatic tap, the amount of blood in the first tube is less than the second tube and the third tube. So it gets more the more you go, because you bleed more. So the amount of blood per tube can be an indicator of whether the blood is fresh blood from trauma or old blood. Because the other reason for blood in spinal fluid is a hemorrhage. Now, if you hemorrhage into the brain space, you have all the same signs you would get with meningitis, apart from the fever. you have neurological symptoms. So it may be that you've bled. So we normally do sequential counts. Count the cells in the 3 tubes and compare them. They should be about the same. If it's prior bleeding, dramatic tap should be going up. If the spinal fluid clots and you end up with clear fluid with a blood clot in the bottom, it only clots with fresh blood. So a clot is an indicator of a traumatic tap. When you spin down the fluid, if the supernatant is slightly orange in colour, we call that xanthochromia. And that orangey colour is from broken down red cells, which implies the bleed was prior, it's old blood. So there's 2 different indicators there of whether it was a recent bleed from trauma or an older bleed from some prior hemorrhage. And then we do microscopy. We want to get this spinal fluid and count the cells, because you should normally have less than 5 white cells per cmm. I should do it in litres, but I'm too old for that. I forget. So for me, it's in cubic millimetre. Less than 5 is normal. More than 5 is abnormal. In a neonate, maybe less than 20 is normal, because they have some cells if you're a neonate, but not many. When they're positive, you have got hundreds of cells. I mean, it's not hard to recognise a positive one. And you count the cells. You want to count the cells and separate neutrophils from lymphocytes and red cells, obviously. Now, separating the red cells is easy because they look so different, but separating polymorphs from mononuclear cells is more difficult, because most times these are not stained. You're not doing a blood film and staining it. You've got a counting chamber and it's liquid, unstained. So what you can do is use toluidine blue, a small amount of blue dye, and the blue dye will stain the nuclei, and you'll be able to see whether they're polymorphs or whether they're mononuclear cells, and separate them. If you want to, you can just do a total white cell count, and then take some more spinal fluid, spin it down, do a deposit, do again to stain the hematology, and then do a diff, and apply that diff proportion back to your total cell count. A bit cumbersome. It's also good to use some acetic acid. Take a tiny bit of glacial acetic acid, tiny bit, add it to your CSF in a separate tube, and the acetic acid will lyse all the red cells and will also lyse the outside of the white cells and just leave the nuclei. Makes it easier to count. And then do a gram stain. You know in our gram stains over in microbe, we also these big round things, stain deposit. When you're doing a CSF, you might see one cell, one microbial cell, be enough to make you nervous. So you can't have your stain being messy. So you must always filter your stain. So what I do is I actually take some filter paper and hold that between me and my slide and pour my stain through the filter paper. And that way all the crap in the stain, which gets there all the time, is taken out of the way. Otherwise you get bits of rubbish on your stain. How reliable is a gram stain for diagnosing meningitis? Less than half of those CSFs that are culture positive are positive by gram stain. So gram stain is terribly non-sensitive. It depends on the number of bacteria in the spinal fluid. If you have about 100,000 bugs per mil, the sensitivity is about 95%. If you've got 1,000 per mil, it's about 10-15%. If you've got 100,000 per mil of bacteria in your spinal fluid, you're dead. So by the time it's a good test that's sensitive, it's too late. So in other words, the gram stain is not that good, because to be of any value, you want to intervene early, not late in the disease. And when it's early, there's not enough bugs to get it positive. But when they are positive, they're great, because the range of bugs is so limited. If you see small gram-negative bacilli, it's probably Haemophilus. If you see gram-negative Diplococcus, it's a Neisseria. If you see long gram-positive cocci, it's pneumococcus. Not hard. But we can do other stuff. Let's just dump straight down to here. Miss this for now. Just down to here. It's possible to take the spinal fluid and look in there for antigens of the common organisms because they all make capsule. And we can now have kits that have latex particles coated in antibody against HIB, strep pneumo, common serotypes, Neisseria, common serotypes, E. coli. I don't think we cover Listeria. We cover E. coli. So you put your spinal fluid onto the slide, add your 6 bits of latex, mix it. Oh, it's POS4 pneumococcus. Great. Really good. The downside is, because the number of CSS we get in now, the number of positives is very, very low, prevalence is very low. With low prevalence, you compromise specificity, or PPV. You do get occasional false positives for agglutination. The one thing you should never do is predict positivity. And by that I mean this. If you do a gram stain and you think you see some small gram-negative bacilli, you go, might be Haemophilus. I'll just do a agglutination test, but I'll only use one reagent, my Haemophilus reagent, and it goes positive. You are taking a risk because it may be a false pos against latex. Always test all 6 of the reagents at the same time. Nothing's more annoying than someone just choosing one bottle out of a set of 6. And then at the end, the kit's buggered because you've got one bottle that's empty and 5 are still half full. So you must do this all the time. Use all 6 because if you get a false positive, it's most likely will cross-react with more than one of those reagents, not just one. To make these tests have a better PPV, it makes sense to use the test when there's other indications of infection. Because the problem is, for reasons I don't understand, there are lots of CSF that come in that are never ever going to be infected. Things like other neurological diseases where they take CSF and we just culture it out of habit. So only do this test for microbial antigens in the CSF if they've got a strong white cell response. There's no point doing that test if there's no white cells, because all you're doing is lowering the PPV of the test. So do it when it's indicated. And you can do this test on blood or on urine, because as the bug is growing, it's making excess antigen, which is then coming out in other body fluids. It'll be in serum, it'll be in urine. And sometimes there's not enough spinal fluid to go around. Get some blood and do it off the blood. When we culture, we always culture for everything in spinal fluid. And you never ever use plates that are selective because there's no point. You'll only ever get one bug in the spinal fluid and you want to grow it. So plain chocolate agar in CO2. That'll grow the Haemophilus and the Neisserias. And then blood agar in CO2. You tend not to need to culture anaerobically, other than to help you, but because the range of bugs is so limited, doing cultures anaerobically is a bit pointless. And you may do other plates, like you may do a Sabro's agar plate if there's risk of fungal meningitis. And there's one particular fungus which yeast that commonly causes meningitis, which we'll talk about next semester. We normally use specimen number 3 for microbiology because number 3 is the one that's got the least chance of contamination. The first specimen might have some skin flora, second one a bit cleaner, third one more clean. If you can't, any will do, but normally we use number 3. And it's better to culture not the plain liquid, whole meal, spit it down and culture the deposit is much better yield. Okay, on Friday we'll cover things that we haven't covered yet, and most of that will be talking about bugs that are multi-resistant and ones that you acquire in hospital. So that'll probably go for about an hour and a bit, and then we'll do a little bit of talking about the exams and the format for the exams, both the theory and the prac exam. Okay, see you Wednesday.
Hey, Steve.
Yes.